Welcome to another episode of the Stephen McCain Podcast, where I bring you people making world-class decisions in the field of human optimization and performance so that you can look, feel, and perform your best. Today, I'm very excited to have one of my favorite doctors in the whole world on the podcast, Dr. Elizabeth Yurth. She is a double board certified physician in physical medicine and rehabilitation and anti-aging and regenerative medicine. She has more than 30 years of clinical experience and continues to stay at the forefront of orthopedics, cellular medicine, regenerative medicine, and the future of aging. This is a cellular medicine doctor, and I really want you to see from this podcast how cellular medicine is really where all the magic is happening. That's where all the research is being done on the field of aging. And when you understand cellular medicine, the approach becomes far more efficacious and sophisticated. And we dive into some pretty cool topics about how to properly do NAD supplementation, her thoughts on exosomes, hormones, new novel way to address arthritis, so many great things. I think you're going to really enjoy this podcast. So let's do this. Dr. Yerth, welcome to the Stephen McCain Podcast.
Good to see you, Stephen.
Yeah, I'm so excited for this one. I just absolutely adore having any opportunity to chat with you. I will never forget the first time I ever saw you at the World Peptide Congress a couple of years ago. And it was just a panel and you up there and you started speaking. And I said, this woman knows what she's talking about. And it's been that way ever since. Every time I've seen you speak. So you're one of my favorites. And I'm excited to share your knowledge with my audience and just let's see what comes of it, because every time we talk, it seems to be very interesting.
Well, I appreciate that so much, and I'll give you back the same kudos because I love listening to you, and I love you coming at this from a very practical sense, right? I mean, we as physicians sometimes throw out all these things, and people like you are the ones who kind of refine it into, well, I did this and this and this and this, and this works and this doesn't work. It's really good to hear that, especially from somebody like you who comes from this very high performance attitude, which is really fun to work with anyway. Those are the kind of clients that are always fun to work with. So it's I love to live off your feedback on all this stuff, because those are the people you're like, okay, this guy is really optimized, and if this isn't working in him, what are we doing wrong? So it's you and I always have fun talking about that stuff.
Yeah.
So
Well,
my mutual appreciation for everything you're doing.
Fantastic. It's nice for someone like me to really be so motivated by this industry and to be able to fit in and feel capable of doing that, because, when you're surrounded by, I talk to more doctors than any other type of person now. I'm constantly ripping apart their protocols. What are you doing? What are you doing? And so it's nice to be able to fit in. I mean, I was pre-med at UCLA, so I have some of
that and then decide to be an Olympian anyway. That was a good plan.
Yeah. Yeah. I wish I could have knocked out both, but I like who I am. So I think it's all.
Well, it's funny because as much as, if I look at what I learned in medical school, it was nothing to do with what I'm doing now. And I would say if anything kind of distorts your brain a little bit to be able to learn these new things, because you're so start, in these paradigms of medicine that have just been going from generation to generation to generation, and not much really ever changes in medicine. And it's funny, when I first got into this field, I don't know, many, many years ago now, probably 17 years ago, I started kind of transitioning more into this kind of work. And, and I was like, wow, I'm learning from bodybuilders. I'm actually not learning from physicians anymore. I'm learning from these people who are actually more performance athletes who said, okay, like my first delve into, even back then when A4M was 500 people, and there wasn't a whole lot of research in this area, and we didn't have the Dr. Seeds out there. That it was a lot learning from people who were just sort of using N of one experiments on themselves, and it was the bodybuilders and the people like you, and we learned a lot from that, right? We learned a lot from the people who were like, okay, this is my optimal performance piece. And so it's very funny that I would say early on in this world, I learned more from that group of people than I did from the medical world.
Yeah, I mean, that's so interesting, because it seems like with doctors, you go through this whole 12-year process. I don't know how long it is. I think it's 12 years, and then your education kind of seems like it just
Stops.
begins.
Right.
Right.
And
Like
nobody wants to learn anything more. I always tell people it's a little bit like, you spent all this time building this incredible house that, and you spent all this time and energy, and then your friend walks into it and they're like, wow, I wouldn't have done it this way. This sucks. This sucks. This sucks. And you're not gonna even listen to that, right? You just spent 10 years building this gorgeous house that you think is perfect. And now when somebody comes in and says, probably not,
Yeah.
you're like, la, 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 I don't want to hear it. And so, it's really hard to change physicians. They are very set in their paradigms, and changing that is almost impossible. It sometimes is impossible. I will tell you, like, I came from the orthopedic world, like Bill Seeds, and coming from orthopedics, which is about as far a cry from doing anything sort of health focused. And these guys don't want to ever hear that we should be doing anything different, because they're making good money and they're doing well replacing your joints, and why should we change? And
Yeah.
I did solely orthopedics for 17 years before I ever started studying longevity, functional health medicine. And then I tried to do both. And my partners finally came to me and said, you know what? We don't do medicine here. We do orthopedics. You need to stop getting labs and stop talking to these people for 30 minutes. And I'm like, okay, obviously this isn't working.
Yeah. Wow. Yeah. And it's also probably compounded by the fact that these orthopedic surgeons are, I mean, trust me, I've been operated on many times as a professional athlete. They're rock stars. Like I've been operated on by literally
Right. So
rock
really
stars of orthopedics, and they're tremendous at
what they do. Right.
what they do. But if you don't have to open me up and there's another way to do it, utilizing cellular medicine, well,
Right.
I'm all in on that if possible,
Or
and
prevent most of orthopedics is not fixing your broken bone, right? I mean, you had acute injuries, you had these things with gymnastics, but that's not most of orthopedics, right? Most of orthopedics is your people developing arthritis. It's the, nursing along people who have a worn out joint and putting steroids into it until you replace the joint. That's most of orthopedics. Certainly, we're never going to not need orthopedics to fix my broken bone, or, I couple months ago completely tore off my rotator cuff lifting and needed to be put back together. That wasn't going to be fixed by cellular medicine, but I could markedly improve the recovery doing those things
yeah,
and prevent the outcome of progressive arthritis that occurs when we do surgeries on people. So I think the difference is, let's take away that, orthopedists should fix your broken bone or put together a tendon that tore, you tore your anterior cruciate ligament, fix it. But where we're failing is in all those other people who are simply have sore joints and they're being treated very poorly, with the ultimate outcome being replace the joint, which is, I mean, does it work? Sometimes, sometimes not. So
yeah.
we're doing a lot of things wrong in that world, and that's where they're not rock stars. They're rock stars that they're one little piece, right?
Yeah, it's a really good point. A friend of mine, he works in medical sales and makes great money. And his opinion, he does all these joint replacements. And to me, that stuff just seems like medieval medicine in a way. It's like, well, are we
Right, just
really
hack
doing
out the
it?
joint.
Yeah. I mean, when you look at like actually what they're doing, like this is kind of modern medieval practice. And his opinion is by the time you're 60, you just start needing this. And I'm like, no,
No,
you
right, and
don't.
that's the whole problem. That's where, where I started looking at orthopedics. This is not We're not wearing out our joints. You don't wear out your joint any more than you wear out your brain or you wear out your heart. It's an inflammatory disease, just like all those other diseases, just like brain diseases or heart diseases. And so when you go in there and you're 50 years old and you tore the meniscus in your knee and your doc's like, well, let's just go clean that up and trim it up. I always tell people it's a lot like going in with your demented mother and the doc going, well, let's just trim out those bad parts of the brain. That'll be good. She'll be fine. That's exactly the same thing. So when you look at arthroscopic surgery,
Oh,
which has been banned in every other country over the age of 30, nobody else will do it because the data is so compelling that it worsens arthritis. It's the number one surgery done here in the US for orthopedics, is go up, clean out a joint, trim up a meniscus, and yet it leads to a rapidly progressive arthritis.
mm,
British Medical Journal 2019 said there is no more data needed. There's so much data to support that this is a bad surgery doing bad things, that they will not allow it. And yet we are doing it dime a dozen here.
yeah.
And we're trying to treat an inflammatory disease process, which we well know now, because now we have drugs and things like that we know are working on the inflammatory pathways that halt the arthritis and even reverse it. We know that we're dealing with altered inflammatory pathways and not just you wore out your joint because you were an athlete.
Yeah. It's so interesting. I'm definitely all in on talking about this stuff because I've had both, I had two meniscus tears, one in each knee, and they just trim around it and they cut that out.
Turning around, right?
And one of them my knee's 100%, but the left one, I'm wondering if I have a little bit of some muscle imbalance issues
Arthritis.
around it, or if it's starting to slightly show a little, a little bit of maybe pre-arthritis or whatever arthritis. I mean, it's not bad. I'm still feel
Right,
pretty
right. You
amazing.
can do everything, but you've got a lot of years on it. So here's
Yeah.
what we know about arthritis, right? So we know that when you look at people who are developing arthritis, and it's most of those people who have painful joints, is it's a combination of factors. There's genetic factors, and then there's injuries that can progress things. But when we get an injury, what is supposed to happen is our body comes in and it tries to clean things up, right? So best world, you get this inflammatory reaction, all these cytokines, these pro-inflammatory enzymes come in hard at work and they try and clean things up. That should last a few days. Then those should turn off and we should turn on some healing processes, right? But let's say you don't have the perfect genetics or you don't have the perfect lifestyle, then what happens is these inflammatory proteins, things like tumor necrosis factor alpha and interleukin 1 beta, stay elevated. And as a result, instead of just cleaning up a little debris, they just keep cleaning up. So, for instance, there's this enzyme called metallomatrix protease that is elevated initially in an injury. And it's kind of I like to think about there was a crime in your house. And this is a cleanup crew to kind of get rid of all the signs that there was a crime there. But if they keep scrubbing away the debris, what happens? They actually start scrubbing away the joint. So these very high levels of these metallomatrix proteases are really detrimental to the cartilage continuing to progress. So let's say you tear your cartilage in your knee, all right? And now somebody goes and scopes and they trim out that little torn piece, which temporarily is going to make you feel better because the knee's going to feel more stable. And these pro-inflammatory enzymes come in, they start trying to help out. Then they stick around a little bit too long. Now you start actually not just cleaning up what happened, but cleaning up your own cartilage. So we know very well now that in joints, we have very high levels of these enzymes. We have very high levels of these inflammatory cytokines. And that if we block those, that we actually halt and even reverse the arthritis. So we need to stop thinking of this disease as a wear and tear. It is completely and utterly an inflammatory disease process. And so we are
That's right.
using a drug, a repurposed drug called pentosin polysulfate. So pentosin polysulfate, which is been approved in Australia made by a company called Paradigm Pharmaceuticals it's called xylitol. It's in phase 3 trials here in the US to cure osteoarthritis. And in fact, in Australia, it's done just that. It's reduced the need for joint replacements by almost 90%. The
Wow.
1-year follow-up studies showed almost 25% improvement in cartilage space after 1 year on this drug, 25% improvement in cartilage space in an arthritic knee, whereas the placebo group had a 4% loss in cartilage space. So not only are we helping pain, but we're actually reversing the disease process. And that's all by using a drug that is blocking these inflammatory processes, right? So we know that we can reverse it by stopping the inflammatory process. You don't have to just, replace the knee joint. We can actually reverse this process. So this drug's in phase 3 trials right now here in the US. We actually can get it compounded because it is an orally available drug here in the US called Elmeron. So orally, it's for bladder inflammation. But if you inject a little sub-Q injection of it a couple of times a week, it actually works systemically and at a much lower dose. So systemically to actually stop this arthritic process. And oftentimes within 12 weeks, people have reduction in pain. It takes longer to start seeing the changes in cartilage space. And sometimes people take a little longer, but it's dramatic. And I've been on this, I have horrible arthritis in my knees. I've torn my ACLs 4 times.
Oh,
And so anybody who looked at my knees would say, oh my God, you just need joints replaced. But I have zero pain. I'm totally functional because I'm on this medication. I've been on it for now 3 years. It's dramatically reversing. Now, I have lots of patients who we can treat for a short period of time and they get better. I kind of need it ongoing. If I don't take it, I start over time, over a few months, it'll start increasing a little bit of pain in my knee. So I know that whatever my genetics are, I need to block these enzymes. I need to block these cytokines that are doing the damage.
yeah.
But Stephen, it's actually dramatic, and and it's going to make a huge shift in how we treat arthritis. it's getting it'll get approval for knee osteoarthritis. It's good for any kind of osteoarthritis and backs. So it did the same thing in a rabbit model using pentosin. They actually stopped disc degeneration. So,
Wow.
and the drug's all been around since the 1980s, as an oral medication. So its safety profile is good. It's been, and again, we're using a micro dose of what they have to use orally for bladder stuff. So we're micro dosing it. It also, very interestingly, at a low dose orally. So we've also had it compounded as a very low dose orally, which doesn't work as well for osteoarthritis. But a low dose orally, it's really good for the gut. Some people who have gut issues, it helps the gut. And it's a potent antiviral, anti-cancer, and anti-atherosclerotic agent. So this is because when you
Wow.
look, all these diseases have some overlap,
Yeah.
right?
Yeah, exactly.
They're all
Inflammation is,
inflammatory diseases, right?
yeah. Fantastic. I remember I saw your presentation on this at the World Peptide Congress this year, and I was enamored because I've put a lot of mileage,
Right.
dynamic mileage on my joints, and I have to take really good care of myself. Fortunately, I have pretty minimal pain, but I just think this is like a perfect example of a repurposed drug doing
Right.
something that is
Right.
a huge need, right? And what was this thing you were saying though in your speech about it potentially causing blindness if you took it for so long at such a dose?
So the big thing, so Elmeron, which is the drug, last 2020, I guess, or 2019, they put a black box warning on the drug, and a lot of lawsuits went on because after this, again, this drug's been around a long time, right? But they started to see an incidence of people who had a retinopathy that was associated. It was very unique retinopathy. They'd never seen it before, but it was causing damage to the retina of the eye, and in some people, some progressive loss of vision. And what they found was it was a dose dependent. That's why it took so long to actually see this, because you had to be on the drug at a high enough dose for a long enough period of time. And those people, when they looked at their eyes, so then they brought in asymptomatic people who had no problems with their vision, but they looked at them, and in a small number of people, they did see these changes in the retina. So they said, "Oh, big black box warning." Big lawsuits went out on Elmeron, and and it got prescribed less and less orally because of that. Now, if you look at the true incidence of that, number one, you have to get to a high enough cumulative dose over a lifetime. So
Okay.
remember, we're using a microdose. That dose is 500 milligrams done every day. We're using a microdose of that. We're using microgram dose of that, or 25 milligrams orally, and not on an everyday basis. So for us to ever hit the cumulative doses that was ever seen to be associated with this retinopathy would take you taking this drug regularly for about 80 years of your life. And maybe I'll be on it for 80 years. I don't know. Hopefully then we'll have a treatment for retinopathy. So but so it got kind of overblown, as things do here in the US. Now xylitol, if you look at the FDA or the whole printout on the pharmaceutical, xylitol, the injectable form of Elmeron or pentosin, they left that off completely because we actually don't think it's going to be a risk factor done as the injectable. Now that may be a dose dependent thing, and it may be a difference in how it's metabolized. But it doesn't appear that it's going to cause the same problems, at least not with the animal studies. They was not supported. So if you look at the package insert on xylitol, it doesn't say that. And it is funny when you look at Elmeron, even, which is widely used in other countries as well. They have no black box warning or no warning about the retinopathy. So that may be a little bit of a thing here, because it's about 0.0001% of people that will develop this. But
Okay.
our lawyers like that kind of stuff, right?
Yeah.
That's huge money when you get a group of enough people who have a disorder, and you can make a whole lot of money off of it from a drug company. So, you know, so I think we have to take that with a little bit of, okay, yes, keep a cautious eye, but not abandon this drug because of that.
Cautious eye, no pun intended.
Yeah, right.
And would there be a time where you'd want to go off of it? Like, is that, like you said, if you're shutting down some of these things that clean up, would you, like, if you,
It seems to be really regulatory, right? So it's not going to shut them down completely.
okay.
It's going to help modulate the currents of it, right?
Okay. Got it.
So you can use it more as a modulatory agent than you can really being a clear. It's going to shut everything down. It's probably just not potent enough to do that. And you don't do it every day, so you're doing it on an intermittent basis. So you're doing it, once or twice a week. You're doing an injection, so we're probably not shutting it down continuously. Now, I do tell people when they have surgery, number one, it's a weak blood thinner, so I tell them stop it for, a few days before surgery. And I tell them to wait a few days till after surgery, pick it back up, just for that very reason, just in case we want to sort of let that inflammation kind of come up a little bit more
Yeah.
beforehand. So I do utilize it that way. I'll take people off for a few days around surgeries, things like that.
Yeah, that makes perfect sense. So that's available. Someone could literally come to you and say, I'm suffering massively with arthritis. Can you help
Yeah,
me?
and honestly, I will tell you, it's been life-changing for people, really life-changing.
Okay. Fantastic. Well, I mean, that's a real piece of gold right there. And I would love to dive a little further on it, but you have so many pearls of wisdom. I did want to talk about this 1-MNA that
Yeah,
you,
let's talk about one, which is 1-methylnicotinic acid, and 1-MNA. So everybody now is very gigged out on NAD, right? You
yeah,
all have heard about NAD, and I think there's very little argument to say that NAD does not decline when we age, and that replacing or getting more NAD is probably good for us. I don't think anybody would doubt it. And I know you had James, what's his name, the big NMN
Ginfinity,
guy.
Dr. She.
Yeah, yeah. I know, you had him on a podcast recently, and he and I got into a big kind of argument at one of the conferences. Um, and it ended with he didn't want to hear what I had to say, so whatever. But and so who knows? Because this is a field where all of us are going to be a little bit married to some of our opinions. But I come from everything, and this is my, you work with Bill Seeds, my Bill Seeds training, coming from everything from looking at pathways and what are we doing? Because Bill Seeds is very big on this. You have to keep things homeostatic. And when we overdo, you take too many antioxidants, you do things, you're screwing up your cell,
Yeah.
right? So now what are people doing? They're like, oh, NAD is really important. We need a lot of NAD as we age. We're going to have more energy if we have more NAD. That's the ultimate electron donor. We make more ATP. We have more energy. We know it declines as we age. We know energy declines as we age. Let's just give everybody NAD. So people are going in there doing these massive NAD infusions or the precursors like NMN or NR, which are basically the same thing. In fact, probably a little better because really there's no evidence NAD can even get into the cell. You have to use one of the precursors to get into the cell. But the problem is, I tell people it's a little bit like, why are our NAD levels declining? We actually don't make less NAD. So that's been well proven in mice models that if you do like what's called a CD38 knockout mouse where they don't have the enzyme to degrade NAD, they don't lose NAD. So it's not that we really make less, at least not substantially. To some degree, maybe yes. But what we do is we lose more. So what happens is we get upregulation of several enzymes. I think Nicole Conlon in her product, which I'm blanking on the name on, where they use she uses niacinamide and kind of a combination of blockers is probably the best kind of so far that we've done with this. But basically, the key is that if I give you a whole bunch of NAD and all you're doing is turning on the enzymes that are degrading it, what have I done? Have I really increased your NAD levels?
You've
At
just
best,
charged those
temporarily.
pathways, right?
Right. So I always like to pick this. It's a big bucket, right? And your bucket is got a hole in it. And it's leaking out all over the floor. So you're ruining your wood floor, and you're like, oh my God, my bucket is empty. I'm going to keep filling my bucket. And your bucket stays nice and full, maybe, as long as you keep enough of it going. But what's happening is your floor is now ruined. So what happens when you give those NADs is you accelerate, once you've gotten as much as you need, and we don't know what that is, right? I don't know how much you need. Once you've gotten as much as you need, your body's pretty smart. So it's got to get rid of the excess. So it does so by a couple of enzymes. And one of the main ones is CD38. And so people have said, okay, well, let's block CD38. That's a great thing. And it does, it helps. So blocking CD38, and you can use things like epigenin to block CD38. So you can block that drain a little bit there. But body's still pretty smart. And so now it's like, okay, we still got too much. We block CD38 and it goes down another pathway. And there's an enzyme called NNMT. And NNMT is really upregulated in cells that are not so happy, like your cancer cells, your senescent cells, your fat cells. They have very high levels of NNMT. So now what your body's doing is it's sensing there's a whole bunch of drain of NAD. It turns up NNMT. And interestingly, it does so to actually make another product called 1-MNA. This is all really technically difficult. Sorry. Make another product 1-MNA. So you're doing two things. You're making 1-MNA, which is trying to sort of help you, and you're feeding all these cancer cells, senescent cells. So NNMT is being looked at very actively in the cancer world because if you block NNMT, you seem to be able to reduce cancer cell metastasis. So there's a lot of work going on in that realm. So now we're giving people NAD and NMN and NR, while the rest of the cancer world's trying to block the enzyme that you just accelerated by doing that.
Yeah.
Right? It's a little worrisome that the rest of
Yeah.
the world who's in the traditional medicine cancer world is like, ooh, block this enzyme. And we're doing things that are turning the enzyme up.
Yeah. Well,
So,
let me.
go
I
ahead.
didn't mean to cut you off if you're on a roll here.
Oh, go ahead.
So you have CD38 and NNMT, which are
Correct.
these two enzyme pathways that are stealing, and they each have their own sort of downstream effects.
Effects, right.
Usually you would do apigenin to kind of tamper CD38, and you would
38.
use maybe 5-amino-1-MQ for NNMT, right? So does this one MNA help for both of those pathways or just the NNMT?
So basically the feeling is that the CD38 is probably less important as a regulatory than as you get downstream to that NNMT. So 5-amino-1-MQ is great because 5-amino does block NNMT. And that's why it's so good for cancer, and it's so good for producing more energy and helps with weight loss, right?
Yeah.
The problem with if I block NNMT, I will build up NAD and I block the cancer cell growth, but NNMT makes 1-MNA. And 1-MNA is actually a really good thing. It actually, in and of itself, helps cardiac function, helps lung function, helps energy and metabolism. So now we've blocked all the bad stuff, right? But we've also blocked one of the good things. So a company in Poland, very small company in Poland, came up with a molecule, 1-MNA, which is basically just a food source, right? 1-MNA, 1-methyl-nicotinic acid. And they said, so when 1-MNA, so if you picture this pathway with NNMT going to 1-MNA or NMT going to cancer cells, right? Mm-hmm. Once 1-MNA gets filled up, it's going to turn off NNMT. It's like, I've got enough 1-MNA. I'm going to turn off NNMT. So now I've actually kept the good thing I needed, 1-MNA, because I'm giving it to you. I've blocked the bad thing because I blocked NNMT, right? Mm-hmm. And 1-MNA is something I can take orally, and so it's 5-amino, but orally on a regular basis, keep that really nice adjusted, keep this really active molecule, the 1-methyl-nicotinic acid, which actually has NAD-like properties, so in and of itself has really good properties for that. I've blocked cancer cell growth, and I've got the best of both worlds, and it's a heck of a lot less expensive than 5-amino-1-MQ. So the problem with this company, which was making it in Poland, is they were trying to get it to the U.S. as a drug because it's really good for cardiac stuff. It's really good for obesity. It's really good for cancer. So they've been trying for the past few years to bring it to the U.S. as a drug. So they were starting some trials on it for a drug, and so they would not sell it to the U.S. as a supplement. So when we came across 1-MNA, we're like, my God, it does exist. Somebody makes it. But it was this little pharmaceutical company who would not sell it to us in the U.S. So we're like, damn, can't get it, impossible to get. And so we spent a few years flying to Poland and meeting with this company and finally kind of hit them at the right point where, and what we told them was, listen, it's going to take you 15 years to ever get this thing through the FDA. And then you're going to have to get physicians adopted to it, which might not be that easy. We'll help you utilize, get this here as a supplement, because we had some working with some other international companies to help people transport stuff, get things to the US. So we had some expertise in that realm, not me, but another company I work with. And so they finally, and I think we kind of, because we like been in these discussions for a while, and I think we finally kind of hit them at a point where probably they financially were getting like, maybe we need to think about something else. I don't know. We finally, got them compelled by saying, okay, let's just keep this as a supplement. So it's taken 2 years. We finally have it to the U.S. as a supplement. It should actually be available. If you guys go to just 1mna.com, it should be available as a supplement. I don't know for sure, but I think the company says within a week.
It's now.
It's now. Is there
I
now?
was literally waiting to purchase it until I had this conversation with you, because I saw your talk and I was like,
yeah. To us, and and Bill Seeds, he's actually, as usual, the first one to kind of turn me on to this. But it is sort of the answer to all this NAD, because we do need more NAD, but we need to do it in a safe fashion. And all you guys who are doing NAD infusions and taking tons of NR and NMN, and like I said, that's why I got into a big argument, and and his argument was, I feel better, everything's better, it's obviously working. And I think the problem is that you will temporarily potentially feel better. You're also releasing a lot of some inflammatory proteins when these senescent cells get turned on, and sometimes that actually gives you a little bit of a rush. So when people like do an NAD infusion, like, oh, I felt all this rush of energy, it's actually not necessarily a good thing. It's because you had this rush of inflammatory stuff that was released from the senescent cells because you just fed a whole bunch of senescent cells exactly what they wanted to grow. So I think you have to be really aware and cautious. And I think, the problem is that we're doing a lot of things that we don't know enough about. And I think this is a place where we're doing harm. And
Yeah.
believe me, I'm just as guilty. I was doing a lot of NMN and NR and recommending that stuff. I always did it with a CD38 blocker. So do you need the CD38 blocker? I don't know the clear answer to that. I take both. So I'm gonna take one MNA and a CD38 apigenin because I feel like, okay, that's probably gonna be my best way of keeping these stores really perfect. On the upside, CD38 doesn't form anything bad, right? Although it's
Okay.
draining some of your NAD, it's not forming anything bad. And I am getting the NAD up by the 1 MNA, so I may not need it.
Yeah.
Don't know
It
for sure.
might be nice to offer an escape route if it needs it.
Right, that's exactly right. Like, is that maybe the escape valve that maybe, this is I do have too much, you know, uh, in that reaction phase. Maybe that's
Y-
a nice little, thing because where I get more concerned about is this downward pathway that's feeding the senescent cells, and CD38 doesn't appear to have that same downward spiral unless it
Yeah.
goes down from CD38 down to NNMT. So I kind of think that blocking that downstream will probably be good enough. And maybe you're right. Maybe the keeping the CD38 turned down, or maybe doing it intermittently, right?
Yeah.
Like doing things intermittently,
Yeah,
you
yeah,
know?
and do you know if you get the same muscle benefits of 1-MNA as you do with 5-amino-1-MQ? Because you get this, like, stem cell activation of muscles, like, or
It
some.
really should do exactly the same thing, in fact, even better
Yeah,
as the one MNA.
alright.
So if you look at the data, so there's a really good study on long COVID, improving endurance in long COVID with one MNA that came out last year that was very compelling. There's a really good study on cardiac output, but the long COVID study showed significant improvement in muscle strength, at least in the long COVID group. Now, in someone like you who's already optimized, will we see that? Not sure we'll see it as massively, but it should have the same benefits. You're doing the same thing, except I think better than the 5 amino is.
That's fantastic. Okay, so we go to 1mna.com. I was
.com.
literally just there yesterday. I think right now you have to buy it by the case, but
Well, I don't think well,
no? Well, either way, it's available and I'm
yeah.
buying it
So if you go
because
there, I mean, physicians, so it will be, so it's going to be, so you may have to go to a different site as an individual person. So because the 1 MNA site may be for practitioners. I
what
think that you may have to go to what's called ohphealth.com. If you log in there, then I think you can. That's where I've been sending my patients to buy an individual
okay.
individual supplement. Because
Okay.
the 1 MNA may be for the physician site. They are trying to keep it within more of a professional line, but you can, especially if you're under physician's care. So if you log in and you're under physician's care, usually you can buy it through the OHP Health site.
Okay, got it. Yeah.
.com.
Well, and whatever I dig up, I'll put in the show notes for people that
Yeah,
is
I
the
can I can I can hook you up to the people from who can answer those questions too.
okay, fantastic. Well,
I'm not
I'm
very
excited to because
Yeah, I will tell you from my perspective. So, I basically brought back a suitcase of it from Poland when we went there. So I had a supply for a while, and it definitely improved like energy levels, muscle strength, but definitely endurance for me, which is what I
okay.
find with 5 amino. I'm not sure it improves my muscle strength as much. It improves my glucose control and it improves my endurance. And that's what I found with 1 MNA.
Yeah.
I didn't find, I mean, did you find with 5 amino that you improve muscle mass?
So what I have found with it, I've always kind of recommended it to people like when they first start a new strength building routine, they're getting it started, they're going to do some weights. And I think it's a nice spark because I have noticed that sometimes when you start and you're really rusty and you feel like you have no activation in your muscles, you're like, God, these things aren't even working. But I have found with 5-amino-1-MQ, I just feel like I get a little bit more neural activation in some capacity, And I've also noticed the fat, sort of the fat burning effect or whatever. It seems to have this muscle building and fat burning.
It definitely has fat burning effects when you block and when you block NNMT, you definitely get fat burning effects because you're stabilizing metabolic control. And you definitely, any of you guys who have more of a insulin issues at all, or are on the more heavier side, it can be definitely helpful for weight loss because it's normalizing metabolic control so well.
Yeah, and it is expensive. So this one M&A is
Yeah,
sounds like
5-amino is outrageously pricey.
yeah,
I mean,
yeah,
it is really, I mean, probably less so from research chemical sites, but from our compounding pharmacies, not cheap.
yeah. Well, I mean, this is
Yeah,
so
we're
fantastic.
super excited about this, honestly. I mean, it's been a long time coming, and and I think we're gonna, and I think that it is like 5-amino, like more of an exercise mimetic, so it does kind of act like you're exercising for you. They showed in the long COVID people dramatic improvement in like their 6-minute walk test, their quad strength improved dramatically, and I know a lot of people. Some people not even aware of it, how much COVID or sometimes the COVID vaccine has done in terms of their quality of life in terms of endurance and strength. A lot of people have gotten hit by that.
Yeah,
My practice is now full of long COVID people. I mean, that's been a bad problem.
yeah. And I've seen people complaining that were really optimal individuals. Like at first, I kind of thought it would maybe just be for like the metabolically challenged or people that were really out of
Right.
shape. And
No, these are really healthy people.
yeah, it's scary.
I've had some really high level athletes who have just been down and out, since COVID.
Yeah.
This mitochondrial dysfunction that COVID causes is the hair loss. The hair loss clinics have gone rampant now because of hair loss post COVID. It's all some a mitochondrial loss.
Oh,
It's done a lot of ongoing damage.
yeah, it's not funny. You can end up chasing your tail for a whole year. And so I really think that's when you got to find someone like yourself that really knows these pathways. And I mean, you just dropped two golden nuggets of this pentosin polysulfate, this one MNA. And you talk about how everyone was doing these, it started with these massive NAD infusions, then it got into the precursors because of David Sinclair. And then now
Right, right,
I think this is like the third phase. And in the beginning, I came into this thing as I guess you would call it a biohacker. And now, as I've sort of matriculated and I've tried my best to do as much as I can to learn these pathways or listen to people that know these pathways, but I just find that as you matriculate, you go up, you start getting up into the functional medicine and all the protocols that all the doctors like you are doing, because that's really where you want to play at. Those are the people that you really want to learn from, because you talk about these cellular pathways. And I'd like for you just to take a moment to explain that. So maybe if someone doesn't understand cellular health, because if you optimize a cell, you optimize
right.
the body, right? So maybe if you could just kind of explain why this is so important right now to look at the stuff this way.
Yeah, I think that's really important because so we call ourselves cellular medicine providers. So at Seed Scientific Research and Performance, which I'm on faculty with, so disclaimer: yes, I'm going to be very pro this type of medicine because I truly believe in it. But where it lies different, even from what sort of our functional medicine. So if you think about traditional medicine, it's a disease focused, right? It's okay. You have this disease. These are our protocols we do to treat this disease, right? You have diabetes. This is the protocol. You have heart disease. This is the protocol. So everything's very protocol driven. And then people went, oh, that's not the way we should be. Let's go to functional medicine, right? Let's look more deeper. What is causing that person to have diabetes? And let's treat more functionally, right? Where did things go awry? But if you've looked at, and this is the hardest thing I think in training physicians or training my clients is that when you go a little deeper than that, what everybody still wants is protocols. Okay, so now you have diabetes. Here's your protocol. You're going to take berberine and you're going to exercise this, and and you're like, well, guess that didn't work for me. Why didn't that work for me? Right? So protocol driven medicine, which unfortunately is what doctors like, because it's really nice to have a cookbook. Well, okay, now I have this, I'm there. So they've got metabolic dysfunction. Here's my protocols. And, and there's a lot of, and it's one of the things like A4M teaches a lot of protocols, and people like protocols. I
Yeah.
get it. It's easy. The problem is protocols don't always work. And so what you have to go back down to is at the cellular level, what pathway started you down that road? And that's where you have to relearn biochemistry, and nobody wants to relearn biochemistry. We all hated biochemistry the first time, right? Somebody told me actually the Krebs cycle was important. I was like, oh God, and now I literally spend all day long trying to learn new pathways because every year we discover new pathways. So I can actually look at a disease and say, okay, this weird pathway, something called like the C gas sting pathway, these weird ass pathways are what actually are starting this process of you going down this road. So now I have to actually go back to where in this pathway that's gone awry in you do I need to intervene? So it's really looking at this pathway driven inside the cell, these pathway driven responses that are causing the underlying metabolic dysfunction, which cause the diabetes, and diving down that level. And there's not protocols to treat that because everybody's going to be a little bit different. But I can say, okay, wow, all these things are going on. I know it must be a dysfunction at cytochrome 2 in my mitochondria. So you have to get down to that kind of level to really treat some of these more complex things. And I'll say not even complex, but some of the simple things. And it's not easy, and it's not protocol driven, and it takes tons and tons of time and research and education to do. So it's not for everybody.
Yeah.
But ultimately, it's going to be what makes us be able to heal hard to heal people or really truly prevent disease. Because if I keep all my cell pathways going the right direction, if everything's working right, then I won't develop this or this or this. But it's so incredibly complex, Stephen. And I will tell you, like I said, some of these pathways, like the C gas sting pathway, which honestly, if you look at it, it's a root at a whole bunch of different diseases, and yet it was discovered in 2019. I mean, so you can't hang your hat on the things you learned in medical school 30 years ago, because every year we're discovering some new pathway, some new mechanism, and you have to keep up on it. So it takes tons of reading, it takes tons of time, but it's so much fun because then I can look at, okay, this person's exhibiting all these things. It must be a defect here in this pathway. Now, what can I use? Be it a peptide, be it a repurposed drug, be it a supplement, be it a change in their exercise routine that will actually alter that specific pathway and cure a whole host of dysfunction down that road, right? So it's super fun to do, but you'll go down these rabbit holes of researching things for 8 hours at night because you're like, oh my God, where can I make a change here, and how do I change this? And sometimes it's super simple things, right? Like a baby aspirin and how much you can do with a baby aspirin a day.
Yeah, I mean, it's fascinating. I've been at the World Peptide Congress for a couple of years now. I sat there I got to speak at it this year, but before I was in the back just wide-eyed and just learning,
right.
Jesus, these people you're speaking a different language. I call it,
right.
do you speak cell? That's usually what I tell
Yeah,
doctors.
there you go. I like that.
I'm good friends with, Sandra Kaufman.
Uh-huh.
Yeah, so she speaks cell, and every time she explains something, she's
Right.
speaking through. So, like for me, I'm always striving to learn as much as I can about these pathways, and because I understand that the people that understand the pathways are the people that probably understand some issue
Right.
the best. At least
Right.
that's the best snapshot we have right now. We can't look quantumly at the issue yet, but we can look at it.
And AI is going to make this even better and better, right? When we can actually now feed a lunch and say, okay, this is in that pathway where you need to intervene, and then I can say, okay, give me a list of the drugs that might potentially do that, and and be able to pull more of those. People always, I hear this from all my patients, right? Oh, I don't want a pharmaceutical. Well, pharmaceuticals are not evil. I mean, there's a lot you can do with pharmaceutical drugs.
Yeah.
That is great. And people, people are like willing to take a list this long of supplements because they think they're safer. And I'm like, actually, I probably have one pharmaceutical drug that may actually address all of those pathways that you just are trying to treat with your 15 different supplements. So a lot of these like repurposing drugs, I love that because a lot of these drugs have been around. They are safe. They are good. So for instance, there's a drug we use a lot called amlexinox, and amlexinox it was approved for aphthous ulcers, for canker sores, as a topical. So it's called Apsol, and it was approved for canker sores, and then the little company that made it really didn't go very far with it, so it sort of got abandoned. But what it does, the pathways it works on, and if you look at it, there's a great article on, is this sort of the cure-all for everything? Because if you look at the pathways it works on, it's incredible the number of diseases, from autoimmune to cancer to hypertension to obesity, that you can treat with this drug now because it's available, the compound's available, and Amlexox is available in the US. So we have a compounding pharmacist make it into a basically a tablet for us, and people can orally take it. And I will tell you, it can be remarkably life-changing for people from autoimmune diseases, things like that. It is frankly a remarkable drug. It's another repurposed medication. But when wow, this pathway is really important. Here's a drug that actually addressed that pathway, used for a completely different purpose. I can now pull that in and do a whole lot of things. So when you understand these pathways, now I can search for things. I can say, okay, I need this pathway altered at this spot. Give me the drugs that do it. And technology has allowed us now to really be able to come up with a list where I can feed that into ChatGPT, and it's going to say, okay, these are the drugs that have been discovered that work there. And, now I can play with that. So don't close your mind to all the things that really medicine has and is available if we use them in the right way.
Yeah. I remember for like years ago, I kind of went through this phase where I was like, oh no, I don't do any
I'm not going to take a
medications.
drug.
And then, hey, I take, 5 milligrams of Cialis every day because it improves my blood flow.
That opens your blood vessels, reduces your risk of dementia, helps prevent stroke, right? Yeah, it's not for your erections. It's because, I put almost all my patients, women and men, on 5 milligrams of Cialis, because if you look, dementia risk is reduced, hypertension risk is reduced, cardiovascular disease is reduced, all by taking 5 milligrams of this simple drug. Exercise performance is reduced. That's why it's banned as a wadded banned drug, right? Because it actually has significant benefits on exercise performance. So, those are exactly, your patients are like, what? I'm going to take 5 milligrams of Cialis every day? I'm like, yeah.
Yeah, I mean, I consider that to be an operating system upgrade, because you improve blood flow to
improve blood flow, right?
every organ, everything gets an
exactly,
upgrade.
every organ.
Everything.
And your brain being a big one, right?
Yeah. So like I've completely opened my mind up to this stuff. And the beauty about this off-label usage is the fact that it's already gone through all the rigors.
It's already gone through the testing.
Yeah.
Right, exactly. It's like, you've already got the safety data there,
Yeah.
more so than a lot of supplements do, right?
Yeah. Well, especially Jesus. Yeah. The supplements that's like a wild, wild west, I mean,
right.
Yeah. I mean, this is fascinating. We're 46 minutes into it, and I'm like, oh God, we haven't even gotten into like peptides, for crying out loud. But I mean, look, let me ask you this. What are your thoughts on hormones? Because a lot of these people that speak cell, these doctors, they're like, well, if you optimize the cell, you don't need hormones. And I'm like, really? Like on all cases, like, I,
Yeah, I will tell you, I don't agree with that. I mean, we know that our hormones decline. If I optimize the cell, can I keep my hormone levels up to where they were when I was 20? I will challenge that. And I know, you and I are very fond of Bill Seeds, and he's very much speaks that you don't need to do these things. You can do everything by cell optimization. I don't see it. I think that, we were just talking about that recently, because he said nobody needs thyroid medication. I'm like, there are people who need thyroid medication, so my belief is that you need to try and keep the body in a state, even when our cells were working great, we're 18 years old, right? And everything generally was working well, our hormones start to decline. Our hormones start to decline early, right? Our hormones start to decline in our early 20s. I mean, 25, you start dropping your hormones down. By 30, you're on the downward slope. And,
100%.
and that's not just cell health. It's just what happens in terms of some of our organ decline. Can we maintain that better with doing some things? Yes, we can lengthen it out. Can we get them back to where they were? I don't think so. So I'm a little bit of the belief of I'm going to replace everything that I definitely am losing, right? Mm-hmm. And that's going to help my cell function better. So I'm going to go on the reverse, that I can improve cellular function and cellular pathways if my hormones are there. And maybe I can reduce the dose of the hormones as the cell functions better. But, peptides in our body decline as we age. We know that BPC, which is an endogenous peptide that our gut makes, that those levels decline as we age. Mm-hmm. Even if I keep my cell healthy, those levels decline as we age. So do our thymic peptides. We don't have thymus glands. There's nothing that maintaining your cell health is going to do to give you back a thymus gland. It's not. Yeah. Your thymus gland is at its biggest at puberty, and then it starts shrinking down. And, by your time in my age, it's a little fatty nub that's not making thymic peptides anymore. So I'm not getting thymosin beta 4, which helps with me with growth and recovery, or thymosin alpha 1, which helps my immune system, and improving the cells not going to all of a sudden make my thymus gland regenerate, or my pineal gland not calcify. We can help it, but those things. So my feeling is, your pineal gland calcifies, you need to give apitalin. Your thymus gland is going away, you need to give thymic peptides or thymic bioregulators, periodically to keep that function that you don't have anymore because you don't have it. Your ovaries are not going to work as well. Do I think you need hormones? Your testicles are not going to work as well. Yes. I think most men are going to benefit from testosterone and estrogen and progesterone. And I'm going to have to say, I think that's what's going to help keep my cellular mechanisms going as opposed to vice versa.
I couldn't agree with you more. And granted, I'm not some doctor or whatever, but I've paid attention
Right.
and I've paid attention through the point where I'm about to turn 50, and there's these cycles of being alive that these
Right.
things start to shut down,
Start to
or
go down,
they,
right.
you become resistant to anabolic signaling. You don't fold proteins as well. You don't
Right.
make as much stuff. I mean, it all starts to cascade into something. And my opinion is, I look at hormones as a communication system. I'm like, do you remember what it was like to be on dial-up? I don't want to be on dial-up. I want to be on broadband. Like I
Yeah.
want, I want the muscles to get the signal. Hey, let's grow. It's time. I just worked
Right.
out. Like, let's do
Right.
this, but I see a lot of that, and it's refreshing to hear your opinion that kind of feels like intuitively like where I'm at,
Right.
that you have to just start propping the body up as it ages with all the
Yeah,
things that
exactly. Again, it's the replace what you're losing bit, right?
yeah.
I'm going to replace those things that I'm losing with time, and that's, I mean, can you keep growth hormone levels up? I mean, even if seeds is in that he fixes the cell and everything gets better, then why do you need growth hormone secretagogues, right? But people need growth hormone secretagogues, or to keep growth hormone levels up. I think that hormone levels are going to decline even in the face of self. And again, I think that if you look at a lot of cellular mechanisms, that even like mitochondria they function better with estrogen. So you need some estrogen for mitochondrial function to be better. So I think that there's a piece there of, I don't think you're going to independently fix the cell and all of these hormones pick back up. I just don't think that's the way our bodies are designed.
Yeah.
But who knows? Maybe we'll learn more in a few years.
Maybe this is the NAD
We just,
precursor
we're
phase of
just
this.
right. We just keep learning and changing our protocols as time goes on. For
Yeah.
now, I'm using hormones.
I've used HCG for a monotherapy because I was
Yeah.
trying to maintain my fertility, and I've started to see. I had this guy on the podcast. It hasn't been released yet. This guy, Zach, and he was basically he's been turning menopausal women back and making them fertile by putting stem cells in their ovaries,
Yeah.
and he has gave me some science that shows that the longer you can maintain your fertility, the longer
Right.
you will
That's a
live.
health factor. That's exactly right. Yeah. There's a lot of research going in that realm and that's like rapamycin showed that too, right? That women that at least in animal studies, that rapamycin maintained fertility, at least started early enough that it maintained fertility much longer, at least in mice.
What is your opinion on rapamycin? Because I have it, and I'm like, I read a book on it, and I was just about to do it, and I had this little pink eye thing or whatever. I'm like, well, I'm not going to shut down my
Right.
immune system for a day to do this. But what is your opinion on it?
So, most of the research on rapamycin has come from Mikhail Blagoslani, who is very well researched in this area, and he has some really good articles out there to really show that this is not an immune suppressing agent unless you dose it at an immunosuppressive dose.
Got
So if we're
it.
using it for cancer, or we're using it to keep you from rejecting your transplanted kidney, and you have to use it at immunosuppressive doses. But at a low dose, it is an immune modulating agent. And I think the data is pretty damn compelling that it is one of the few longevity agents that we have some pretty good evidence to support, right?
Yeah.
At least in every other animal model.
Yeah.
Unfortunately, like Matt Caberlin, did you see this today? Matt Caberlin's, who was doing a big, huge study on rapamycin in dogs, the dog aging project. And so everybody had their dog on rapamycin, and it's been really a compelling project and doing very well. And the FDA, for some reason, just shut it down. Who knows why?
Really?
Their infinite wisdom. Yeah. But
Interesting.
yeah,
That
so it's
must
too
mean it
bad.
works. That must mean it works. I mean,
But yeah, I mean, I think the data is pretty convincing. I think what we don't know is what the proper dose is for us as humans.
yeah.
So most of the longevity docs I know are taking 5-6 milligrams once a week,
Mhm.
but there's people who are doing it higher. There's people who are doing it, 1 week out of every month. Nobody really knows the answer to how we're dosing. The 5 to 6 milligrams is based more on sort of our animal or mouse studies. Do we need more? We just don't know. So I think at this point, most longevity docs have kind of jumped on board with rapamycin. I take it, once a week. I think that it makes sense when you look at sort of, I want to just shut off mTOR periodically.
Yeah.
I want to, have a sort of cleanup. I think that the evidence is pretty convincing. I think, are we dosing it enough to do anything? I don't know the answer to it. Blagasclani thinks not. He thinks here in the US we're probably not dosing it high enough. He doses it much higher himself. So I don't know the answer to that. So I'm probably playing it on the conservative side, and we'll have to see. It's just going to take a lot of time and research to figure it out.
Yeah.
At this point, by what data we have, it looks good. And I think it's very safe. I think it's not immunosuppressive. I don't ever get sick. I take rapamycin. I think that it has good immune modulating properties. I will see it bump up cholesterol. That's probably the biggest negative. Is it will bump
really?
up
It
cholesterol a little
does.
bit. So you will see it bump up in cholesterol in some people. It's usually not the ApoB that gets bumped up. It's usually just the total cholesterol. So and usually ApoB, which is the bad player. Remember, all of you guys who are testing cholesterol, don't look at your cholesterol. Look at your ApoB.
Yeah.
I don't care if your cholesterol is 300. You want your ApoB low. And so, look at your apolipoprotein B. That's the number you need to focus on, and keep that low. Keep that at least below 90. But even lower probably better. There's data now that shows that there's no too low level. It's good, but you want a nice high cholesterol, 200, 250. You want that. So the question is, is it doing anything bad, or is it really just benefiting us and raising cholesterol? But if you go to your doctor who doesn't look at ApoB and just looks at cholesterol, and all of a sudden your cholesterol is 300, they're going to go, oh my God, well, So sometimes you will see that in people.
Yeah. Well, I think if anybody's learned anything from this, and if someone, whoever's listening to this probably already kind of knows what I'm about to say, but in listening to you and that there are these doctors that understand this cellular pathways, God, if anybody's listening to this podcast and they're still in the traditional medical system, let this be your notice right now that, like, hey, there is a much better way to do things, and they're just, and it's your life, for crying out loud.
Right.
It's your
I think that's the
life.
hardest thing. I mean, you and I spend a lot of money on this stuff, right?
Yeah.
People, and I know you've talked to Brian Johnson, and you guys have interacted, and people are like, "Oh, we spend $2 million a year. How stupid is that?" I'm like, I have patients who spend $2 million a year on their stupid horses. I mean, it's like, to me, it's like, I have patients all the time who they come in and see me who have plenty of money, believe me. And I recommend these protocols that are not inexpensive. You're right. And they drive out in their Lexus, to get their $9 Starbucks coffees. And I think we've got to learn to prioritize that this money spent on health is the most important place to put your money.
Yeah.
I mean, it's probably where most of my ancillary income goes. Unfortunately, probably I have no social life or anything. I just take a lot of supplements and peptides.
You're the same person. I mean, we're all cut from the same cloth.
Who needs friends?
Yeah. Oh my goodness.
I've got peptides. It's I think that is a place where people are still in this paradigm of, well, insurance doesn't cover that, and it's a lot of money, and and I think once you're sick, I mean, I've had cancer patients, stage 4 cancer. Now they're willing to put in whatever amount of money it takes to stay alive, right? But what we need to do is put in whatever money it takes to stay healthy, within our means, obviously, whatever money it takes to stay healthy, starting before we get sick, which is always a hard thing to convince people of.
And look, most people are on the financial investment track that they believe in compounded interest, right? That they're gonna put so much money away every month, and over time they're gonna benefit from the compounding interest. Well, my opinion is, okay, you spend a little bit of money up front on all this pay as you go stuff to be, and it's not a ton as you're, in your 20s. As you get older, it will get more. But if you can get 10 more usable, productive
healthy years where you feel good and active, and
that is going to
huge.
add to the compounding interest of time. So you can make it up on the back end, but also at the same time, I don't ever really want to retire. I always want to be doing what I'm doing. And if I can be totally, that's why everyone's talking about health span, like if I can just be like full faculties till the day I,
Yeah, we want to just do this and then die, right?
Yeah.
This is what most of us do, right? And
Yeah.
at the end, the last 10 years, and any of you who've gone through, gone through aging parents. My parents lived into their 90s, but it was not a good last few years, right? It was,
Yeah.
not easy, right, for anybody. And that's what we really want to avoid. We want to go like this and then boom, fall off a cliff, right? Yeah.
Yeah, exactly.
Um,
I mean, and it's funny because you look at like Suzanne Summers who died, and people were like, what happened? What happened? And I kind of thought about that. I was like, huh, health span. She just, huh. It was like,
yeah, I mean, she was doing pretty. I mean, she was really good for, really until her cancer came back. And, I think her last really month wasn't good, or even a few weeks, honestly. But she was doing podcasts right up until like, it was a little shock to me. I was like, oh my God, she died. I just saw her podcast like
yeah,
a
that
couple weeks ago.
to me, I was like,
Yeah.
there's a perfect, sort of. I mean, not perfect. I mean, but there's sort of like at least a
Right.
semblance of this health
Yeah,
span
she
sort of.
looked good, she felt good, she was having sex, she was, exercising, she was doing podcasts, she was interacting with her family.
Yeah,
Unfortunately, cancer got her, and maybe that could have been dealt with in a different way. But,
yeah,
that you're right, that she was really an epitome. It's funny, when I first at A4M, she was a guest speaker. I don't know, a few years ago. It was a while ago, maybe 3, 4 years ago. And I was like, oh my God, Suzanne Summers, right? Suzanne Summers is a guest speaker. She was really compelling, right? I don't agree with everything she does, but she was very compelling as a speaker of, exactly that she is, and her husband, Alan is like, I don't know, 89 years old. And the guy, they're just still talking about having sex and running around naked and,
yeah,
and all the stuff that we all want to be doing when we're 90 years old, not
yeah.
in wheelchairs being pushed around our nursing homes.
I went and saw 2 years ago. I saw the Rolling Stones here in Vegas, and Mick Jagger was 78 at the time, me and my friend were joking before they came out that they were going to be wheeled out, they were going to be propped up on all this stuff and be super geriatric. And the whole time at dinner, we're joking, making as many jokes about that as it was a running joke. And I know human bodies well. I can watch when someone moves. I can tell if they have hip pain, ankle,
Right,
bad
right,
knees. I've studied people moving for years when you just coach and do gymnastics.
right.
Nothing. He,
It was
besides his face, which clearly has aged,
right,
I couldn't see anything that was any
right.
different than when he was
Yeah,
in his
jumping
prime.
around, I know.
Metabolically super fit, and his movements, he had other move. I cried. My friend was taking social media things and posting the whole time, and I'm sitting there with tears in my eyes because I'm like, this is so inspiring because
Inspiring, right, that
for
people
so
can do that, right.
yeah, because like for me,
And he didn't even take care of himself, so it's like,
yeah, I mean those guys were
where did that come
weren't they
from?
doing blood transfusions because they were doing so many drugs between concerts like back in the
Yeah.
day? I mean, Jesus. Well, look, we've covered some good stuff. I wanted to ask you, is there anything that you are seeing that's kind of coming, or is there anything you've come across that maybe you haven't necessarily we haven't spoken about, or you haven't made a lecture about, or maybe it's like I mean, there's some interesting things out there, and I'm always curious what people maybe are kind of dabbling in that no one knows about.
Yeah, I think that, the big place, like you and I were both at A4M this year, and I kind of went through, and I always go through, like, if I can find one kind of new cool thing, and there wasn't anything huge there, but there's some cool work going on with some of the immune antibody stuff, and I think that might be a player. Like, so this is something called galectin-3, and galectin-3 is elevated in a lot of bad diseases, but particularly in Alzheimer's. And galectin-3 may be more the etiology of Alzheimer's. We keep blaming amyloid, probably not amyloid. It's probably this galectin-3. And so this company's making this antibody to galectin-3. And we're actually signed up as a research trial center to do this. They're only approving it for Alzheimer's right now. But if you start looking at this and you look at galectin-3 in obesity, in cancer, in most of the diseases of aging, it's elevated. And so can we now take these drugs that are antibodies to these molecules that we're making in too much of, and start binding out some of these bad things and
Hmm,
really treating diseases. So I think some of the focus we're going to start seeing a little bit is going to be on some of these immune modulating things, using antibody therapies to actually, for cancers and things like that. I think that's probably where this focus is. I mean, the results, Stephen, you should have seen some of these videos of these Alzheimer's patients with just like 1 or 2 infusions of this antibody to bind this galectin-3. They went
really?
from like one guy they interviewed, he didn't even know his daughter's name sitting next to him, right? 2 months later, they interview him. He's like, yeah, he's talking like a normal person. He's like, I'm actually driving a little bit, driving short distances to the store. It was remarkable. And
Wow.
they had case after case like this. Nothing have I ever seen that had those kind of results. And I think as we start looking at things like that, well, where else can we start using the same that same technology, as time goes on? The biggest thing is so many of these things are so pricey, so expensive, that makes it hard. But I think that's something we're going to start seeing is where can we start using some of these antibodies against bad things that, so as we can do things like with, looking at metabolomics and looking at abnormal proteins that are being expressed and now saying, okay, this person's doing this their body's doing this very poorly. And now I can form an antibody that stops that from having any kind of bad effects, and then work upstream to try and fix why the bad effect occurred. So I think
Interesting.
we're starting to see a lot more of this immunotherapies and treating all sorts of diseases, cancers, Alzheimer's, probably obesity.
It's
And that'll be a cool place to keep an eye on.
Yeah, it's almost like a alternative. Instead of gene therapy, doing
Right.
it at the
Right.
source, you're basically just doing it at the metabolite, like the
Right, a little further
downstream.
down the road. Yeah, and I think gene therapies, I mean, if I could afford follistatin gene therapy, I think that's pretty cool, right?
Do
So
that? Would you do the
and
follistatin one?
I don't know if I would do it just yet, but I mean, I heard Liz Parrish speak at RadFest. I mean, she did it years ago, right? Because Liz is on the leading edge of all that stuff.
Yeah.
But it's pretty compelling. I mean, I guess the scary thing is, are you doing other things that we're just not quite aware of yet,
Yeah.
right?
Yeah.
But you look at the results of some of these people, it's pretty impressive with the
Yeah.
fall stand. But right now it's $25,000 and it lasts about a year and a half, and then you got to do it again. And again, I just am not 100% certain that there's not things we're doing when we're screwing up at that gene level. Are we doing anything that we just don't have quite a handle of? I just
Yeah.
don't know yet.
Yeah. I'm a little, like there's the telomerase one Liz Parrish does. I
Right,
remember
Liz Parrish, right? Yeah, right,
yeah.
yeah.
My first
So
podcast guest, Paul Tozer, like a friend of mine, he did the follistatin, the telomerase, and I mean,
he's done it all around.
I was like, Jesus,
And
that's
does
like,
he feel great?
yeah, I mean, yeah, he was a hard charging guy who worked in like video game development. So
Huh?
he basically tested he basically said his telomeres were like gone, and so it
Right,
was a
right,
little bit of an emergence.
right.
And he's shown whether or not these look. That also brings into question, like, are
Right, this
these
question,
tests?
are these tests right? How good are these tests, right?
Yeah,
We could talk all day about that one too,
yeah,
but
because they're measuring the average, and it's really about which ones are the
right, that one.
shortest. You have these modalities that people are doing, like the follistatin and the plasma exchange, and
Right, young plastic change, yeah.
I'm a big I like exosomes. I mean, maybe that's the last thing. If we could have one little final, uh, get your opinion on exosomes, because I know you guys had exosomes at World Peptide Congress as one of the booths and stuff. So you guys always recommend the vendors that are there. What are your opinions on what is your opinion on exosomes?
So we look at, we I think nobody would deny that stem cell therapy has significant benefits to our health. And I saw you had, I can't remember his name, but the stem regen guy, he and I had this big talk about stem
Christian.
cells a little bit. Yeah. And it was brilliant. And, and I love his product, and it certainly has some good outcomes. But, one of the things I said to him, I said, well, there's a lot of data supporting that our own stem cells as we age may not be, we used to think, oh, stem cells don't age. I said, there's some data to support that actually is not true. Some of the Chinese data that's coming out shows that aged stem cells.
Uh
Are you
oh.
there?
There I am.
You disappeared for a minute. Okay. Aged stem cells actually did have senescent phenotypes, and that they actually doesn't do some damage down the road. I had a discussion about that. I don't know if we figured it out, but if you think about probably the best stem cell sources, it still is probably taking young stem cells, so taking umbilical stem cells. The problem is
Yeah.
umbilical stem cells contain data you probably don't always want, right? They contain information, even DNA information, that you probably don't want. So what exosomes are is they're little nanoparticles contained inside stem cells that contain all of the microRNAs and growth factors to regenerate, right? So if I can take, instead of stem cells, I can take all the guts of the stem cells that have the really good things that I want, the mRNAs, the growth factors that are going to use my own system to design a new skin or new hair or whatever. In my mind, that's the safest and best way of regenerating tissue, right?
Yeah.
Is to use umbilical stem cell derived exosomes. And now I can also take, like, let's say if I can fit, 100, obviously it's a very small number, but 100 stem cells, and each of those contains 1,000 exosomes. What if I take, now whole lot more exosomes. I'm giving 15 trillion exosomes as opposed to maybe not that kind of volume if I'm giving stem cells. So, so I think that you can get better volume. I think you can get better outcomes. I think the data is certainly trending towards some of the new data that's coming out on exosomes is showing some really amazing things in terms of regenerating, even in the face of spinal cord injuries, things like that. I think we have a ways to go on understanding everything about it. But in my mind, everything I know and even in my results in my own clinic, I still think they have the most regenerative potential. I do think you want good sources. I think I don't know if we know enough to say, okay, this is the perfect place to use them, but the data is awfully compelling. And I think that my belief is they probably have the most regenerative potential of anything that we have in our armamentarium.
Yeah, I'm leaning in that, and I've been experimenting with them. This year was like the year of exosomes for me, and tried amniotic and placental, and I've used the placental derived ones for pretty consistently this year, and I'm a huge advocate of it. Even doing it at a lower pulse, but more kind of frequently to kind of
Right.
But it's always refreshing to get your opinion on it, because it just keeps what you're saying is echoing exactly how I think about it. And man, we covered some good stuff on
Covered a
this.
lot of stuff.
Yeah, we covered some good stuff. I feel like we did it justice having you on. It is always a delight to just have a few moments with you. And I got to indulge. So, yeah, I would love to offline. I would love to talk to you about the pentosin polysulfate, maybe coming on as one of your guys' clients or something like that, because I just feel like that's
Yeah, for
something.
you, probably with all the stuff and, if you had knee scopes, I would tell you probably not a bad thing to actually maybe do at least a course of now and then,
Yeah.
you know?
Yeah, I would love to work with you on that, and I really appreciate it. How can people what's the best way for them to find you, reach out to you if they want to work with
So
you?
boulderlongevity.com is our clinic. We see patients from all over the world, licensed in most of the states in the US, about 46, and we see people all over the world, mostly virtual. People who wanna come here for procedures, orthopedic procedures and things, obviously, they have to fly here for doing those things if we're doing more regenerative procedures. But otherwise, we just work virtually with most of our clients. So boulderlongevity.com, you can just sort of fill out and want more information piece there, and somebody will contact you, or you can set up an appointment online. Those of you guys who want to learn more, I love like Stephen doing all this education on this stuff. So we actually tried to set up this thing called Human Optimization Academy. So if you go to bli.academy, you can sign up there. We actually have some free content, and then there's some, if you can join the academy, really cool stuff. So we put together courses there to try and teach people, how do you read your own labs? How do you understand, the stuff your doctor doesn't tell you? How do you understand that? And we try and teach from what doctors should be learning, not and they don't. So we're trying to teach you that way, as opposed to trying to get all your information from your Instagram influencers, who we have to remember are sometimes trying to sell you things. And so we're trying to keep it, it's all, nothing that we do is to promote a product. It's all really just educational. We also do these really fun Q&As. They're kind of like this. People ask really cool questions and we just rap about it, so those are really fun every month. So if you go to bli.academy, you can look at the academy, and we love that. And it's growing the content on that. Again, there's courses on, how do you fix things first? Where do you go? How do I look at my CBC and know whether it's abnormal or not, or my cardiac panel, or my hormones. So we help you to learn how to read your own labs, because you guys can't rely, as Stephen said, you just can't rely on your traditional doctor to do this stuff. You just can't. You're going to have to become your own health advocate. So we're trying to help you to do that. Because even good functional medicine doctors aren't all that easy to find, honestly. So you at least be your own advocate. Find a doctor who you can work with and talk to. When you become as smart as Stephen, then you just, you kind of dictate your own care a little bit, but you want to find a doctor who can help you along that road. When you want a prescription, they can say, okay, I think that's a good idea, or I don't. So that's what you want to find, is somebody who just works as a team with you. And we want to educate you to be able to do that. So boulderlongevity.com or bli.academy, and you should be able to get everything you need.
Yes, and I will put links to all of that in the show notes. You can find those at stephenmccain.com/Yurth, Yurth. Anyone who's listening to this, I hope you see that there's a caliber of doctor out there that is on the cutting edge. And when it comes to your health, I mean, that's where we want to be. That's why I started this podcast, for crying out loud.
Yeah, that's what people can.
Thank you so much for coming, and thank you everyone for
Thank
listening.
you. I appreciate the time, and I always appreciate talking to you.
Thanks
Bye.
for listening. We'll see you on the next episode of the Stephen McCain podcast. Stay healthy. Cheers.